Hello, welcome to today's webinar, Substance Use in Adolescents and Transitional Age Youth, Justice, Involvement, and Homelessness. This webinar is produced in partnership with the ATTC Network Coordinating Office, AMERSA, and the Adolescent Expert Project by NORC at the University of Chicago. This webinar is part of the Transitional Age Youth webinar series. I encourage you to sign up for these other titles at the AMERSA, ATTC, or NORC websites. Today's webinar presenters are Dr. Tamara Itzel Martinez and Dr. Ara Obando. Dr. Martinez earned her medical degree from the University of Illinois at Chicago and completed her family medicine residency at the Amita Health St. Joseph Hospital in Chicago, where she developed an interest in addiction medicine after working at Harborview Recovery Center during her last year of residency. She went on to complete an addiction medicine fellowship at Boston Children's Hospital in 2020 and stayed on as assistant in medicine and as instructor in pediatrics at Harvard Medical School. Dr. Martinez is certified by the American Board of Family Medicine. And in her current role as addiction medicine attending in the Adolescent Substance Use and Addiction Program, she has spearheaded the development of a collaborative partnership between ASAP and the Department of Youth Services. Clinically, Dr. Martinez has a special interest in caring for patients involved in the juvenile justice system. Dr. Ara Obando was born in Bogota, Colombia. She received her medical degree from the University of Pennsylvania and completed her residency in internal medicine and pediatrics at Massachusetts General Hospital. Dr. Obando is also board certified in addiction medicine and is an instructor in medicine at Harvard Medical School. As the family team medical director for Boston Healthcare for the Homeless program, Dr. Obando provides shelter-based medical care to families and unaccompanied youth experiencing homelessness in the Boston area, as well as low-barrier addiction treatment and harm reduction services with a mobile outreach team. Dr. Obando's primary interests lie in immigration, women's health, childhood poverty, youth homelessness, and addictions. Dr. Martinez has no conflicts of interest to disclose. Dr. Obando has no conflicts of interest to disclose. At this time, I'm pleased to present Dr. Martinez.
It's a great pleasure to be with you. The topic I will speak about today is supporting justice-involved youth transition to adulthood and exploring ways in which we can do this in our everyday life. While preparing for this presentation, I came across the excerpt from Campaign Youth Justice Annual Report 2020. I was 16, forced to be a man when I was just a child. I didn't understand the court's language and didn't participate in my defense. My existence was erased, my adulthood shaped by those who had lost their humanity. This was a child sentenced to natural life in Florida. Imagine if you were sentenced to life in prison at age 16, or imagine that your teenager was sentenced to spend his natural life in prison and didn't even understand the process involved in that decision. How did we get here? We're the most powerful country in the world, but have one of the most inhumane disciplinary approaches towards at-risk youth, particularly minority youth, LGBTQ, individuals with learning disabilities, and psychiatric problems. One of the most damaging policies, which is still in place today, is the zero tolerance discipline policy, which you might remember originated out of the drug policies in the 1980s. These became popular in response to growing concerns about drugs, fighting, and possible gang-related activity in schools that led to the creation of the school-to-prison pipeline via suspensions, expulsions, and arrests, affecting hundreds of thousands of students. Contrary to what those policies were intended to do, the Committee on School Health reported that suspension and expulsion can worsen academic problems, delay development, and place youth at an increased risk of substance use and involvement with the juvenile justice system. Ironically, the committee also noted that children most likely to be suspended are those who most need the assistance and supervision of professionals. You may be wondering what sparked my interest in working with justice-involved youth. The short answer is that there was no identifiable inflection point in my life, but rather a culmination of various experiences, including youth mentoring through Big Brothers Big Sister, my undergraduate Jesuit education at Loyola University, New Orleans, and doing a fellowship in adolescent addiction medicine at Boston Children's Hospital. When I met with my mentee for the first time, I expected a typical visit in which we would get to know a little bit about each other, attach a face to a name, and gain a bit of comfort. What I did not expect was to learn about the heaviness in her heart resulting from intergenerational trauma tied to addiction and incarceration. As we got to know each other, I learned that both of her parents were incarcerated for drug offenses, and her grandmother had been granted custody of her. Naturally, experiencing family separation and displacement creates psychological distress, emotional dysregulation, and academic problems. It was really no surprise to me that my mentee was struggling with all three. I quickly learned that mentoring a child of incarcerated parents was unique in many ways, and shockingly more common than I thought. Louisiana, where I grew up, is second in the nation for the most number of people incarcerated per capita, making my mentee one of many children in Louisiana facing significant setbacks. Mentoring at-risk youth is a privilege and involves providing extra acceptance, attention, encouragement, guidance, and hope. Unfortunately, many schools that enforce zero tolerance policies only see the tip of the iceberg, the child's disruptive behavior, defiance, or chronic tardiness, and fail to adequately explore the feelings, emotions, struggles below the surface. These are missed opportunities to identify, intervene, and treat problems before they spiral out of control. The Jesuit education I received at Loyola University equipped me with an informed view of the workings and systemic failures within our sociopolitical systems, inspired me to believe that we can do better, and prepared me to ask why. For example, why haven't we been able to improve equal access to substance use treatment? Why are medical conditions like substance use still criminalized, and more so in underrepresented communities? Why is there an overrepresentation of minorities in the juvenile justice system, while at the same time an underrepresentation of this medically underserved group in healthcare? Asking these questions and understanding their origins gave me insight of what I ought to do as a physician. As fate would have it, I now work as an addiction medicine attending in the adolescent and young adults substance use program at Boston Children's Hospital, where I have clinic time dedicated to justice-involved youth with substance use problems. In response to the national prevalence of undertreated substance use problem among adolescents and young adults, we are spearheading an advocacy project that is focused on improving access to substance use treatment and health outcomes of justice-involved youth. The fact that 90% of adults with addictions started using substances in their teen years incites a sense of urgency to reach as many adolescents with substance use disorders at the onset of the problem. Part of our goal is to be proactive and take our addiction medicine services directly to justice-involved youth committed to DYS. While DYS currently offers substance use treatment, it's primarily in the form of psychotherapeutic monitoring or counseling. The specialized field of addiction medicine has much more to offer and can complement the services provided by DYS. Both organizations have partnered to provide full access to addiction medicine and mental health services, which would in turn improve health equity for medically underserved adolescents. The way to best illustrate this partnership is to envision a multidisciplinary team approach involved in the care of a diabetic patient. The team is composed of different specialists, an endocrinologist, nutritionist, podiatrist, ophthalmologist, etc. Each provider's role is distinct and does not overlap, but contributes to the team's overall goal of improving the health and well-being of the patient. In the same way, addiction medicine specialists are part of the larger medical legal multidisciplinary team, which may include a caseworker, residential clinician, regional clinic director, and clinic manager. Our shared goal is to reduce recidivism, improve health outcomes, and foster a healthy transition to adulthood. Although evidence-based treatments exist, we know a large gap exists between the number of those with substance use problems and those who receive treatment. Studies show that more than 2/3 of justice-involved youth report a history of at least one substance-related problem. Yet, over 12% of youth in residential placement are in programs that do not offer any substance-related services. This has the greatest implications for Hispanic and African American youth, who are most likely to be in the programs without these services. What does the DYS ASAP model look like in practice? For one, the clinic is entirely virtual. The process starts with a referral from DYS, and from there, our ASAP clinic coordinator sets up initial medical appointments with the patient and parent or legal guardian. These visits occur separately. After completing these visits, I meet with the ASAP team to discuss the case and finalize the treatment plan. I then meet with the legal guardian and patient to go over our treatment recommendations. After I receive consent from the patient or the legal guardian to discuss his or her treatment plan with the DYS staff, I have a separate meeting with DYS staff to coordinate care. After those steps are complete, treatment begins, and I meet with DYS staff every couple of weeks to discuss the patient. If there is a grievance, concern, or change in a patient's disposition, for example, a patient is transitioning to an independent living facility, we will invite the patient to attend the team meeting. This is done to show transparency and to cultivate an environment of trust between the patient and his treatment teams. These meetings are valuable to the patient because they provide a safe space to practice self-advocacy. Supporting justice-involved youth with substance use problems begins with openly discussing addiction as a brain disease. It's important to build this foundation of knowledge during clinical encounters, as it gives the patient a background to better understand addiction from a medical perspective. It's equally important to educate medical and non-medical providers caring for this patient population so that they too can create a culture that promotes healing and reduces stigmas concerning addiction. Successful development of youth into young adulthood includes positive psychological self-perceptions and skills building with the hopes of achieving autonomy, competence, self-advocacy, and some universal societal markers or milestones like marriage, becoming a parent, owning a home, etc. It's important that we remind justice-involved youth that these valued societal markers can be theirs as well. So what are some of the challenges to a successful transition in this patient population? Research has shown that many justice-involved youth have experienced a high number of adverse childhood experiences and disruption of normative adolescent psychological growth. When they come into contact with the juvenile justice system, many times the encounters or interactions may not be developmentally appropriate. For example, supervising staff in detention centers and correctional facilities may have very little knowledge of child development. The lack of training can be especially damaging to youth with learning disabilities, a history of trauma, and other mental health problems. At-risk youth with mental health disorders are a targeted group, particularly during the transition from adolescence to adulthood, a period when they are more vulnerable and in need of more support. More often than not, they have more risk factors than other children and fewer protective factors. In fact, 70% of youth who enter the justice system have a mental health, sensory, or learning disability, and anywhere between 28% and 43% of youth in detention or in correctional facilities have special education needs. African American youth are 43% more likely to have a learning disability than youth in the general population, and American Indian youth are 80% more likely. LGBTQ youth are overrepresented in the juvenile justice system, are more likely to be seriously maltreated by other youth in the system, and may receive excessive punishments, including secure confinement, due to court biases or misguided attempts to keep these youth safe. Boys represent 83% of arrests for violent crimes and in general serve longer terms in detention than girls. Girls, however, make up 61% of all runaway cases and spend twice as long in detention facilities for status offenses. And as per race and ethnicity, underrepresented minority youth are overrepresented in the juvenile justice system. This occurs nationally. And having said this, there is a real concern about the inconsistencies of gathering and reporting data on race and ethnicity. Specifically, when looking at justice-involved Latino youth, this group continues to be almost non-existent in the juvenile justice data. According to UCLA's Latino Policy and Politics Initiative, agencies across the country and within states do not collect data on Latino ethnicity. The lack of the inconsistent methodology for counting Latino youth within states and across the nation undermines efforts to assess the extent to which these youth, their families, and communities are affected by the juvenile justice system. As a result, the largest ethnic minority group continues to be invisible. Today, Hispanic youth represent 25%, or almost 8.3 million of the total US youth population between the ages of 10 and 17. State agencies involved in the criminal justice system collect data that identifies Hispanic youth inconsistently, if at all, creating an incomplete picture of Hispanic ethnic data. States report racial and ethnic data inconsistently across the 3 points of contact: arrest, detention, and probation. In preparing for this presentation, I looked at the demographics of justice-involved youth in Massachusetts and was a little surprised by what I found. The following slides were taken from the Commonwealth of Massachusetts Department of Youth Services Annual Report, Fiscal Year 2020. In Massachusetts, we can see that the average age of first DYS commitment is 17. 15% were females, 85% were males. We can see that the number of first-time commitments is decreasing over the past 3 years, which is good news. As we can see, there is a disproportionate percentage of minority youth committed to DYS. Latinos represent the majority of DYS committed population, approximately 42%. But however, this could be higher given what we know about the inconsistency in data collection. While approximately 33% of youth under the age of 18 in Massachusetts are youth of color, they represent 70% of the DYS committed population. DYS uses a grid system to categorize offenses based on their severity, which consists of 6 grids or levels of severity. Grids 1 and 2 involve drug possession, among other offenses. Grid 1, as you can see, includes operating a motor vehicle with a suspended license, marijuana possession over 1 ounce. Grid 2, OUI, liquor or drugs, possession of heroin, assault and battery. Grid 3 can include stalking, arson. Grade 4 can include assault to murder, assault and battery with a dangerous weapon with significant injury. Grade 5 can include assault and battery on a child with substantial injury, armed robbery with firearm, and grade 6 can include home invasion, rape of a child under 16 with force. These charts illustrate that the majority of youth held in detention by DYS in the fiscal year 2020 was for grade offenses 2 through 4. The average age of youth in detention was 15.9 years and the median age was 16. Detention is a crucial early phase in the juvenile justice process. It's the point at which the courts decide whether to confine a young person pending their court hearing or while awaiting placement into a correctional or treatment facility, rather than allowing the young person to remain at home. In 2017, the median time in placement was about 68 days, 23 days for youth placed in detention versus 114 days for youth committed to a correctional facility. 76% of the detention admissions in fiscal year 20 were youth of color. Latinos represent the majority of detention admissions, about 40.8%, followed by African American 30.6% and white 21.4%. On the right, you can see that the DCF involved youth represent about 45.2% of all detained admissions in 2020. This is a high percentage. So what can we do to support justice-involved youth? A study published in Adolescent Research Review in July 2020, titled Psychological Resilience Interventions to Reduce Recidivism in Young People, a Systemic Review, found that findings from the 14 studies reviewed showed that increasing psychological resources was associated with reduced offending rates, increased time to reoffend, and reduced severity of such offenses. This is not a surprise. Overall, increases in positive affect and coping and decreases in negative affect and aggression positively were related to reduced reoffending. The mechanisms by which these changes take place appear to include cognitive function, such as positive self-concept, and reduced negative attitudes. These processes may be instrumental in supporting a successful transition into adulthood. Medical providers play a critical role in fostering a positive self-image and promoting the health and well-being, with research linking low self-esteem to mental health issues, including addiction and poor quality of life. It's imperative that we try to improve the patient's self-esteem with every opportunity we get. We can cultivate a positive self-image in this at-risk youth during every patient encounter. It's effortless and proven to work. We can encourage patients to make a list of their positive qualities, encourage them to define personal goals and objectives that are reasonable and measurable, remind them of how far they have come, remind them of their resilience. Additionally, another important way to make a meaningful connection with justice-involved youth is simply to have practical knowledge of the juvenile justice system and the unique problems facing this patient population. Understanding the hardships, for example, isolation, legal concerns, embarrassment, shame, will make communication more effective. For example, imagine being 16 and having to go to the pediatrician's appointment in handcuffs and shackles. These traumatic experiences are unique to justice-involved youth, and we simply cannot ignore them. Cultivating a positive self-image is very difficult in these cases. For starters, one has to convince these patients that their true identity is not reflective of their hardened criminal appearance. The humiliation of wearing shackles and handcuffs in public can have a lasting effect on adolescents' mental health. Patients are impacted by the effects of labeling, stigma, and negative self-image associated with a criminal conviction. When substance use is involved, providers have to remove an additional layer of stigma. As medical providers, it's important to address the stigma associated with substance use. Doing so may be life-saving. Many patients I know didn't know that addiction is a treatable brain disease from which patients can recover and continue to lead healthy lives. They believe that their willpower would be sufficient to stop drug use. Fortunately, as medical providers, we are in a distinguished position to educate and clarify misinformation. We can begin by educating our patients as well as colleagues to avoid using terms like delinquent, offender, felon, or criminal. Instead, use words that acknowledge youth's capacity to change and grow. Justice-involved youth is the preferred term. Positive youth development is a well-studied, comprehensive way of thinking about the development of adolescents and the factors that facilitate their successful transition from adolescence to adulthood. Positive youth development is based on a body of research suggesting that certain protective factors can help young people succeed and keep them from having problems. It's the opposite of a deficient-based approach to adolescence, which focuses on what could go wrong. Positive youth development is a strength-based, resilience-oriented perspective on adolescence. And according to research, young people may have fewer behavioral problems and may be better prepared for a successful transition to adulthood if they have a variety of opportunities to learn and participate at home, at school, in community-based programs, and in their neighborhoods. Experts suggest that positive youth development may prevent further youth involvement in the criminal justice system. And some of the ways that this can be done is by encouraging youth relationship with adults other than parents who can serve as positive role models and advisors, supporting positive organized activities such as sports, the arts, or faith-based leagues or groups that give youth a sense of belonging, allowing youth to participate in activities that enable them to be engaged and to feel attached to their community and local events. Emotional intelligence is another evidence-based approach that has been extensively studied. The concept of emotional intelligence is attributed to Dr. Peter Salovey, president of Yale University, and Dr. John Mayer, professor of psychology at the University of New Hampshire. EI refers to the capacity to both reason about emotions and use emotions to enhance thinking and problem solving. According to this theory, these abilities promote well-being and facilitate social functioning. The four abilities constituting emotional intelligence have developed mental trajectories. The emotion skills within each ability area evolve from basic to more advanced and complex. Perceiving and expressing emotion. This skill area involves identifying emotion in one's own feelings, thoughts, and expressions, as well as in those of other people. Expressing emotion refers to the communication of feelings and including the appropriate ways to express them. Youth who recognize the emotional cues expressed by peers or teachers or parents can modify their own behavior and respond in ways that are socially appropriate and helpful in achieving goals. Using emotional to facilitate thought. This ability refers to the use of emotion to think more rationally. It involves taking control of emotions and using them to prioritize thinking. Understanding emotion, this ability involves knowing the causes of emotions, what emotions signify, and how to label emotion accurately. As can be expected, youth with a deep understanding of emotions are better able to use effective problem-solving strategies to cope with negative and positive events, and also to interpret situations from others' perspectives. Regulating emotion. This ability refers to managing the thoughts, feelings, and behaviors that occur with an emotional experience. Youth who regulate emotions well are able to feel the full range of positive and negative emotions genuinely, share those emotions with others, and incorporate coping strategies. So these pro-social evidence-based approaches are counteracted many times by damaging policies like the zero tolerance policy mentioned earlier. Education inequities unfortunately place some students on a path to prison rather than on a path to success. Pervasive structural and systemic racism deliberately embedded in our society create justice-involved youth vulnerabilities. Many of us incorrectly label this patient population as vulnerable patients without realizing that doing so evades accountability of our long history of discrimination. Numerous studies have demonstrated racial bias against youth of color at all level points in the juvenile justice system. One antidote to the school to prison pipeline is RULER. RULER stands for 5 areas of emotional intelligence: recognizing, understanding, labeling, expressing, and regulating emotions. RULER is an evidence-based approach to social and emotional learning developed at the Yale Center for Emotional Intelligence. It supports the entire community in understanding the value of emotions and creating and maintaining a positive school climate. RULER helps students and educators spend more time feeling how they want to feel, valued, connected, and inspired. And it teaches the skills of emotional intelligence so that people can thrive and build healthier, more equitable communities. Studies show that students in the RULER programs are less anxious and depressed, manage their emotions more effectively, are better problem solvers, have greater social and leadership skills, have fewer problems with attention, learning, and conduct problems, and perform better academically. Imagine a society in which children and adolescents could thrive in school without having the fear of being arrested. The RULER approach is beneficial in preventing contact with the juvenile justice system. After a person becomes justice involved, however, it's important to optimize access to safety nets, especially if the justice involved youth has substance use problems. This slide shows a model of the best treatment programs which provide a combination of therapies and other services to meet the needs of the individual with substance use disorders. As addiction medicine specialists, we can play a critical role in the coordination of care, especially as it pertains to reentry efforts and recidivism reduction. I've had the great privilege of working with a 28-year-old who recently transitioned to a community-based independent living residential facility designed to provide educational, vocational, recreational, clinical, and other independent living skills. And as an addiction medicine provider and advocate, I identified the patient's short-term and long-term needs and provided recommendations. Coordination of care was extremely important, as an abrupt interruption in substance use or a delay in care can lead to major setbacks. Unfortunately, many communities lack state or federal funding to adequately meet the developmental, education, and treatment needs of youth placed back into the communities. Once a youth enters the system, once the youth exits the system, they are no longer on Medicaid. And once they are released, they must reapply. This delay keeps the youth from accessing the mental health services they need. And of course, that would increase their risk of recidivism and homelessness, not to mention relapse. So thank you so much for attending. And with that, I will conclude my presentation and turn it over to Dr. Obando.
Thank you very much, Dr. Martinez, for that presentation. I think that ties in nicely to what I will be speaking about today, which is substance use in adolescents and transitional age youth experiencing homelessness. I'll talk about the epidemiology of youth experiencing homelessness, some unique considerations in their treatment, and share a low barrier care and risk mitigation strategies that are helpful in engaging this particular population of youth. So I like this quote from the Chapin Hall at the University of Chicago, which published a report called No More Missed Opportunities, and says that adolescence and young adulthood represents a key developmental window. Every day of housing instability represents missed opportunities to support healthy development and transitions to productive adulthood. And this idea of emphasizing early intervention pertains not only to the experience of homelessness, but also to medical needs. We want to engage youth with substance use disorder as early as possible in their trajectory. And their addiction treatment and engagement around substance use must not only be age appropriate, but also must take into account the uncertainty of housing instability and their many other social needs. So I want to share with you the story of one of our patients named Nick. He first engaged with our shelter-based clinic when he was 18, when he presented for cellulitis. His name has been changed to protect his privacy. He had reported he had been staying on the street for several weeks, and he came in reporting using large quantities of crystal meth and was in withdrawal, feeling pretty awful. He asks for sexually transmitted infection treatment and testing because he'd been engaging in transactional sex with men in exchange for meth. He says he didn't use condoms and was having penetrative and receptive anal as well as oral sex. He has a history of opioid use disorder and had been able to stay connected to a buprenorphine prescriber, but his stability in the setting of housing instability and treatment had become more complicated since starting to use crystal meth. I share with you Nick's story to give you a context around the topics I'll be discussing today, and we'll come back to Nick in later part of the presentation. So how common is Nick's experience? The experience of youth homelessness is hidden and often transitory, making it very challenging to quantify. Young people experiencing homelessness are really a hidden population. Youth may be staying in abandoned buildings, in tents, in the woods, or couch surfing, and may not be counted in the homelessness counts if they're not in a shelter or on the street. The closest thing we have to an accurate count is through the Voices of Youth count, which was conducted in 2016 through 2017 by the Chapin Hall Institute at the University of Chicago. This study included 26,000 people who participated in phone surveys and some in more in-depth interviews, sharing any past or current experience of homelessness. This count yielded numbers much higher than any prior youth homelessness counts, but we have to assume that this is still an underestimate given the method used, which assumed access to a phone landline. The count found that 1 in 10 young adults aged 18 to 25 reported homelessness in the last 12 months. This translates to 3.5 million people, and that 1 in 30 minors aged 13 to 17 endured some form of homelessness for a total of about 700,000 young people across the country. In this count, 29% of youth reported substance use problems and 69% mental health difficulties. A number had experienced some severe loss with the death of a parent or caregiver, and many had experienced systems involvement both with foster care and in juvenile detention, jail, or prison. In thinking about the causes of youth homelessness, in another survey of over 600 youth, 51% reported becoming homeless due to caregiver or parental rejection. And this is something I commonly see in my clinic, where youth share they became homeless when they came out to their parents as gay, or became pregnant, or were caught using drugs, or were arrested and were subsequently asked to leave their homes. The Voices of Youth count also gave us a better sense of some of the demographics of youth experiencing homelessness. Youth who did not complete high school or a GED had a 346% chance of experiencing lifetime homelessness. It's unclear if a lower education causes homelessness or education and other factors that support education attainment are protective. Regardless, this is the strongest predictor of youth homelessness. Black or African American youth had an 83% higher risk of reporting homelessness. And prevalence of Black and African American youth in the youth homelessness population mirrors racial disparities reported in school suspensions, incarceration, foster care, and foster care placement. Hispanic youth had a 33% higher chance of experiencing homelessness. And LGBT youth had a 120% higher risk of reporting homelessness. And these high rates often stem from lack of acceptance in and out of the home. Parenting youth had a 200% higher risk of experiencing homelessness, and you can imagine that this has a significant impact on their children. And in fact, housing instability in early childhood can have lifelong consequences through toxic stress. The experience of homelessness can be incredibly isolating, as you can imagine, with the disruption of social and familial supports. And substance use is often used as a coping mechanism and incredibly prevalent. This is a quote from a young person in the Boston Youth Action Board who provides consultative services to service providers working with this population. And the youth says, sometimes substance use is really about connecting with other people. So how prevalent is it? In this study in 2016, 656 young people aged 14 to 21 experiencing homelessness participated in interviews through the Administration for Children and Families Street Outreach Program. They reported a very high prevalence of alcohol use at 73%, 64% reported marijuana use, and 66% reported tobacco use, with a third reporting use of other hard drugs. In another study conducted prior to our use of the DSM-5, it looked at substance use and victimization in 601 street-dwelling youth in LA, Denver, and Austin. 60% met criteria for substance use disorder for at least one substance with a high prevalence of alcohol use disorder. This study looked at risk of victimization on the street, and those who met the DSM-4 criteria for addiction and dependence of drugs and alcohol had a very high risk of experiencing victimization or violence on the street, which included physical or sexual assault, death threats, and other form of violence. So we're going to switch a little bit and think about some unique populations in the youth homelessness cohort and discuss the importance of relationship building, the high risk for other issues such as trafficking, unintended pregnancy, and mental health needs, and then how the impact of having few parental or familial supports as well as basic needs impact care. So a note on trust building. I had mentioned the high rates of systems involvement in this population, including justice involvement and involvement in child protective services. These experiences engender a distrust in authorities and service providers who might be seen to be in helper roles. This photo is taken from the Boston Youth Action Board Facebook page and was taken at a local forum for preventing and ending youth homelessness. The young lady pictured, Stephanie, is discussing how challenging it can be to engage in healthcare, saying, "It's hard to trust even the people that legally have to keep your trust." She's reflecting on her experience engaging in healthcare. So here are some modalities that can help build the rapport with the youth population. Trust and relationship building is imperative, and it may take many visits before a youth will disclose something like high-risk substance use, and many more before they feel comfortable enough to engage in treatment. Best practices around working with youth and young adults using substances include offering services in a space that is seen as safe and youth-friendly, using a trauma-informed approach that takes into account the very high trauma burden in the youth and young adult population, and using motivational interviewing, which is a collaborative, patient-centered form of communication used to elicit and strengthen a patient's motivation for change. We will discuss risk mitigation approaches separately as well. And I can't emphasize the importance of reducing stigma enough. Dr. Martinez mentioned a little bit about this in our use of using language that is not stigmatizing. We also seek to be culturally responsive and have cultural humility. This gives us a greater understanding of cultures that are different from our own and helps us recognize each patient's unique cultural experience. I also recommend co-locating services as much as possible. So that if you refer to a psychiatrist or a case manager or contraceptive care, ideally, the youth doesn't have to work toward trust building in each separate space, but is all co-located in one space where they've already identified a feeling of safety. So the first subgroup I want to mention is the pregnancy group and parenting and pregnant teens. In one study in the Journal of Adolescent Health, they found that 48% of youth on the streets and 33% of those in emergency shelters reported at least one pregnancy. And this is in comparison to less than 10% of the general population. They found that youth experiencing homelessness initiate sex at an earlier age, report more sex partners and inconsistent contraceptive use, and engage in something called survival sex, which is the idea of exchanging sex for other survival needs, such as food and shelter. And they're also more likely to receive inadequate prenatal care. We know that substance use is also a risk factor for teen pregnancy. And thinking about homelessness and contraception, there are very high rates of unintended pregnancy in women experiencing homelessness. This is related to having poor access to healthcare and healthcare providers prescribing forms of contraception that are less effective. A study looking at women who with opioid use disorder found incredibly high rates of unintended pregnancy, as high as 86% versus 31 to 47% across the general population. As a result of these factors, the American College of Obstetrics and Gynecology recommends the use of long-acting reversible contraceptive methods, which include injection, intrauterine devices, and subdermal contraceptive implants. Those of us treating addiction should screen all reproductive age women for desiring pregnancy and be ready to offer LARCs or any other method of the patient's choice or refer as appropriate. High-risk sex is also incredibly prevalent in the population. So we know that substance use leads to higher risk sex, and this can be unprotected sex, sex under the influence of drugs and alcohol, and multiple partners. In that study looking at homeless youth mentioned earlier, in relation to substance use reporting, they also found low condom use. Only about 30% reported using condoms with vaginal sex, 17% with oral sex, and 39% with anal sex. Subsequently, they found a sexually transmitted infection diagnosis rate of about 20%, with 2% of the young people reporting HIV. So it's imperative to have conversations about safer sex and have condoms readily available, and ideally offer pre-exposure prophylaxis or PrEP at a very low threshold, if possible with same-day initiations, and not only for those engaging in high-risk sex, but also for those engaging in high-risk substance use. Youth and young adults with few resources and no support networks are easy targets for exploitation. Looking at the data around trafficking can be very challenging because of the criminal nature of this, and so we have to assume that people are underestimating, and any report is an underestimate. Youth also may take risks to fulfill basic needs and feel connected to others. They're also easily victimized due to other factors, such as the lack of social support, substance use, mental health disorders. We actually don't have any data on trafficking in our own Massachusetts state counts, but we do know that 13.5% of youth and young adults reported using survival sex while experiencing homelessness, and that 25% of LGBTQ youth exchange sex for money. They also reported the average age of entry into the commercial sex industry at 14 years old. The best data we have on the rate of trafficking in the youth and young adult homeless population comes from Covenant House, which is a network of safe houses and programs that support homeless youth in various cities across the country. In their report, they found that youth engaging in their New Jersey site reported 9.2% rate of trafficking, in New York 14%, and in New Orleans 15% reported trafficking. Due to this prevalence, we recommend screening for trafficking, and I encourage you to know your local trafficking resources and safe houses so that you're able to refer once it is identified. The mental health needs of youth and young adults experiencing homelessness are profound. The high trauma burden locally in Massachusetts reported to be at 72% is further compounded by the experiences of new trauma incurred while being homeless. This can lead to new or worsening depression, anxiety, post-traumatic stress disorder, suicidal ideation, attachment issues, and substance use disorders. Substance use is often used to self-medicate those traumas. In self-reported surveys, 84% of our local Massachusetts population met criteria for a psychiatric diagnosis. And in cases where substance use disorders are comorbid with psychiatric disorders, the substance use is often exacerbated, made more severe, and more prone to relapse. And overall, there is a worse prognosis. The transition to adulthood can be a time of biological vulnerability to the effects of substances. So while substance use may be used to self-medicate a psychiatric condition, the substance use itself may predispose young adults to neuropsychiatric complications, including reduced cognitive function and episodes of psychotic and mood disorders. Ideally, care for substance use and the psychiatric needs are integrated and always take into account the profound trauma burden of this population. Some of the challenges around maintaining mental health stability come with access to care. So there may be lapses in insurance and long wait lists before accessing psychiatric and therapeutic services. Youth often report difficulties accessing and storing medications as well. It's not uncommon that youth will report their medications being lost or stolen in the shelter or street settings. They also have challenges making and keeping appointments due to having irregular phone access and irregular transportation access. And I think this experience is best stated by a youth who was interviewed in the Massachusetts State Plan to End Youth Homelessness, who reported, if you can't be stable, you can't get stable. And he is really describing the catch-22 of homelessness. So what can we do as providers? We can make services low barrier as possible, ideally making them drop in if we're able to, and help with things like transportation, pill boxes, and even setting up some kind of medication storage options in our clinics to maintain youth steady access to their medications. There's a vast amount of data supporting the family engagement and the treatment of youth and young adults with substance use. And as I mentioned in my patient population, there are often barriers to engaging family, whether because of death of a loved one or because the situation may not be safe for the young person to engage with their family any longer. In a recent report in the Pediatrics Journal, there is a supplement dedicated to the principles of care for young adults with substance use disorder. And it reported that in some cases, family involvement may exert a negative influence on recovery. But when able, we want to think about a safe and thoughtful involvement of family, as this is associated with improved outcomes. We want to make sure that the young adult makes a decision to invite the family themselves and also does the outreach to make that invitation, and that they also control the flow of information to the family. I want to also posit that we should consider a broad view of family, and that in many cases where biologic family is not available, we think about including a chosen family or a street family that have become involved with the youth and create a sense of stability. Supportive program staff may also be considered in this setting. Social determinants of health are incredibly important to consider in this population. We have to screen all our youth for access to shelter and housing, food and security, make sure they're engaged in health insurance. Some may not have access to clean clothes and laundry. They may not have transportation access. Their immigration status may pose a barrier to their accessing other services like prescriptions and specialists. They may have a lower education attainment and may need assistance with employment. And as I mentioned, social isolation is incredibly prevalent in this population. If your clinic has a social worker or case manager that can assist with these needs, that would be ideal. But if not, it's important to know your local resources and have handouts or referrals ready for legal support, youth shelters, food pantry, GED programs, etc. This is a quote from Mary Howe, who's a service provider in San Francisco, who says, "I hear a lot of the youth we work with referred to as hard to reach or service resistant, and I can't disagree more with those statements. They are on our streets and in our parks. They are in plain view. How much easier can they be to reach? They want services, but the truth is they want services that accept them for the way they are, provide them with the things they need by people that treat them as individuals with respect and dignity." So I want to share our model of care at Boston Healthcare for the Homeless program. We primarily situate ourselves in places where our patients are rather than expecting them to come find us in the traditional manner, although we do have a federally qualified health center where people can come access our clinical care as well. So the bulk of our work is shelter-based. And through these shelter-based clinics, we offer primary care, gender-affirming treatment, STI testing and treatment, same-day contraception, pre-exposure prophylaxis, Hep C treatment, and many other things. This is a picture of our clinic at one of our youth sites. So we've adapted a room that was given to us to a clinical space where we offer all these services. We also have an insurance benefits expert who makes sure our youth enroll in insurance. We have a psychiatrist on site twice a week, a phlebotomist, and case management. So back to Nick, and that was the setting where I met Nick, in that very clinic. During that first and subsequent visits, we were able to give Nick some safe injection supplies. We conducted STI testing. We treated his cellulitis and abscesses and offered support in accessing a detox, but he said he was not ready each time he engaged. We started low threshold pre-exposure prophylaxis and connected him to our PrEP navigator. Nick returned to clinic intermittently over the next few weeks. He was quickly thereafter diagnosed with hepatitis C. Because of his spotty phone access, we were unable to give him this information, but thankfully, due to a shared electronic medical record, we were able to make sure that this information was relayed to him at the next visit. He was seen at a different clinic across the city. The philosophy of low barrier care encompasses the idea of having a drop-in setting. This way makes it much easier for youth to engage at their own level and at their own pace. We work really hard to normalize accessing medical care, and this might even mean conducting STI testing or immunizations out in public in the Boston Common, because once one youth agrees to having a flu shot and other peers see this happening, they become interested as well. So we make it very visible, very easy to engage, very normal. We also have a complex care navigator that allows us to address the social determinants of health that youth need in order to engage in our care. They can help obtain vital documents such as IDs and social security cards, and they can accompany youth to specialist referrals. We work hard to do alliance building with our community partners, as they are often a source of referrals for us. And we conduct street outreach to really do that trust building in the most hard to reach populations that are very reticent to engage in clinical settings, and with a goal that as we earn their trust, they may one day step into the brick and mortar, engage in our clinical care, in our clinical site. We also have targeted mobile services, and I will share the example of the community care and reach medical van. So we looked at heat mapping data, looking at overdoses, fatal, non-fatal, based on EMS data across the city of Boston. And we tailored mobile outreach to the hottest sites, so the sites with the most overdoses, and sent our medical van to those sites. So this is an image of the community care and reach van, which is funded through the Kraft Center for Community Health, and includes an exam room component and allows us to offer a myriad of services. So this is a busy slide. I will just mention that we offer very low barrier addiction treatment, including buprenorphine, prescribed same day, observed inductions, naloxone distribution, wound care, and more, as well as primary care services, including preventative care like immunizations and chronic disease management. There are clinical hours dedicated to adult patients and evening hours dedicated to youth outreach. Risk mitigation is a large part of the work that we do on the van. Despite being just as affected by the myriad harms associated with drug use, youth do not engage in traditional risk mitigation services as adults do. And this is one of the most important and critical goals of substance use disorder treatment. The goal of risk mitigation is to reduce the rate of infectious disease transmission, notably hepatitis C and HIV, via the distribution of safe injection supplies and practices, and reduce the morbidity and mortality associated with drugs in general, such as overdose prevention via naloxone distribution. Risk mitigation services are also an entry point for additional resources, such as healthcare and ideally substance use disorder treatment as well. So this is what our outreach work looks like. We go out and do street outreach in any season and weather. And you can see here our pre and post pandemic photos with our masks in the photos on the left. These are some overall themes of youth-friendly risk mitigation and engagement practices. So again, we want to create youth-centered spaces that are welcoming. We want to destigmatize access and care. We want to use social media if possible, as this is a means of effective communication with a young population. And along those lines, there are a number of overdose prevention apps and hotlines that can be used. And so it's important to share this information with our patients as well, so that they're not using alone. They can have a FaceTime call with a friend or loved one, or use a hotline such as neverusealone.com. There are also apps like Canary and Remote Egg Timer or KiteString that prevent overdose by monitoring the user's activity after activation. If you stop to engage with the app, it prompts the app to alert someone else, and thus potentially avert an overdose. We want to be consistent, so be there when we say we will. Again, youth have a hard time maintaining appointments, but they might always associate Thursday with the clinic day, so we want to be there when we say we will be. And we use incentives. I suggest the idea of using charging stations, because again, youth with inadequate housing may not be able to charge their phone during the day. The idea of free Wi-Fi, again, which may help connect to other services now, especially with the prevalence of telehealth, and gift cards for incentivizing engagement with care. As appropriate, we want to think about material needs as well, such as distributing food, water, or gloves and hats and hand warmers in the winter. Regardless of the approach, we want to make sure that youth voice informs the design of any intervention. And ideally, we also can engage youth in being peer navigators or peer educators, as they can be wonderful ambassadors to our services. So back to Nick. Last time we saw Nick, he came back after an inpatient detox day, and he had connected with our clinic psychiatrist, and we were giving him his injections of the long-acting antipsychotic in our clinical space. He continued stably on buprenorphine and was doing well in a group home. He came back regularly for a couple of months with plans to start hepatitis C treatment. Our team then learned that he had left his group home. He hasn't been seen in clinic for the last 2 months, but we do intermittently hear about him from outreach workers from the shelter. When he does reappear, we will continue offering support and comprehensive treatment at his pace and in a setting in which we know he feels safe and welcome. So in summary, what I hope you'll take away from today's presentation is that there's a very high prevalence of youth and young adult homelessness, and every patient should be screened for housing instability. Consider if your patient may fit one of the prevalent subpopulations of youth homelessness, such as those that are pregnant or parenting, have mental health needs, are using substances, engage in high-risk sex, are being trafficked, and then connect to or offer appropriate services. And lastly, if ideally we're connecting our youth via low barrier care that emphasizes the principles of risk mitigation, co-located services, and drop-in access. Here are my references. And thank you very much for the opportunity today.
Thank you so much, Drs. Martinez and Obando, for your presentation today. You can access the links to slides from today's presentation and the on-demand recording on the AMERSA, ATTC, and NORC websites. To augment the information provided today, you can check out these additional resources from the ATTC and PTTC networks. You can also keep in touch with ATTC, NORC, and AMERSA via the newsletters and social media. Sign up now for monthly emails and follow them on Twitter and Facebook. And with that, we thank you so much for attending, and this will now conclude today's webinar. We hope you will view all of the episodes in this series. Thank you.